as an opportunity to highlight some of my most favorite students, Dr. Alanna Strong, MD. And as you may know, Dr. Strong is the Assistant Professor of Pediatrics at the Perelman School of Medicine, the University of Pennsylvania, and a Clinical Geneticist at CHOP. Her research focuses on gene discovery and characterization of pathophysiology of fibrocystic hepatorenal syndrome and fibrocystic-spectrum. I can say that in Hebrew too, by the way. Her clinical practice focuses on children with genetic kidney, liver, and ciliopathy-spectrum disease. But what I wanted to say is, since I know Alanna since she's in 10th grade, and I knew that she was destined for greatness when she handed her 10th grade history paper on Christopher Columbus weeks ahead of all the rest of the class. And it's at age 17 or 18, she published a book under the guidance of,
It was
dedicated to a wonderful science teacher. It was called Genetics for Dummies. That was when that series first came out. I cataloged it immediately, and when her lovely young son Brandon came to tour the school, I had him look his mother's book up and find it on the shelf. So anyway, I hand it over to Dr. Strong.
This is really exciting, especially seeing all of my mom go great. But just to give a really big zoom out picture, so I'm a clinical geneticist, and I'm going to talk a little bit about what that means clinically. And then I'm also a research geneticist. And as Mrs. Wendy said, what that focuses on is I do gene discovery for kids that present with liver disease and kidney disease. And so I'm going to talk a little bit about all of these things. I'm super informal, so please interrupt. It makes it more fun for everyone. And I thought that how we would start was just talking about basic genetic principles, so we're all on the same page. Then what is a geneticist? Like, what do I do all day? What is gene discovery and what is gene characterization? So to start with basic genetic principles, what is a gene? So a gene is the instructions to make one protein. So a gene makes a protein, and the protein can do lots of different things, but kind of the classic example is it makes a pigment that gives you an eye color, like brown eyes or blue eyes. Genes are packaged onto chromosomes. So chromosomes are each composed of DNA, and there are multiple genes on each chromosome. So for example, gene 1 might encode a gene that gives you your hair color, and gene 2 might encode a gene that gives you your eye color. But again, this is kind of exponentially multiplied out. Inheritance. Genes are passed down from parents to children. So let's say this is the gene for blue eyes, and this is the gene for brown eyes. And then you have a child, and the child gets the gene for blue eyes, and the child gets the gene for brown eyes. So they'll look like they have brown eyes, but they have both genes there. Now, this happens on a much larger scale. So this is an egg, which comes from mom, and a sperm that comes from dad, and they each carry 23 chromosomes on a good day to make 46 chromosomes for the baby, one from mom, one from dad, each in pink and blue. And then just to kind of highlight this, we can actually look at the chromosomes by size. This is what they look like under the microscope, one from mom, one from dad. And then there are a special set of chromosomes, set 23, that controls whether you're male or female. And so if you have 2 X's, you're a genetic female. And if you have XY, you're a genetic male. Really important things in thinking about pathology. Gene dosage really matters. So it's really important that if you're supposed to have 2 copies of the gene, you have 2 copies of it. And if you're supposed to have 1 copy, you only have 1 copy. So you can have disease because you have too much, or you can have too little.
Is that because you're born that way?
So most of the time it's because you're born that way. In cancer, you can have gains and losses that you're not born with, but acquired over time. Also not a great thing to have either.
But it's not something that it's generally genetic rather it's inherited rather than something environmental.
Great question. So in most cases, it is genetic if you're born with it. In cancer, it can be environmental, but usually it's because
I was thinking like a Lynch syndrome, for example.
Yeah.
As an example of something that I'm interested in.
And that fits more into the second category of gene content mattering. And so in a lot of the cancer predisposition syndromes, it's not necessarily a deletion or a duplication. It can also be a spelling change. So having normal copy of a gene, but a spelling change in one of them that either makes too much of it, so you have too much of a function, or too little of it, so you lose the function, can also cause disease. Does that part make sense? before we go on to what geneticists do once they know what a gene is. So what is a geneticist? So a geneticist works with kids and adults that have differences. These differences can be physical differences, like differences that we see in facial features. They can be organ differences, like IG structural differences in the kidney and the liver. They can be biochemical differences, so difference in blood chemistry. What we do is we look at children either clinically because they have physical differences with an ultrasound or X-ray, or with an MRI or CT to look for organ differences, or we look at biochemical differences in bloods, and then we say, what are these patterns that we see? What does this remind us of? What can explain all of these findings? And then we send genetic testing or blood tests for biochemical testing to get a diagnosis. And it's the diagnosis which is really what we want. And the reason why a diagnosis is so important is because it helps us tell families, we see these physical differences. These are the complications that we anticipate for your child based on what we know about this diagnosis. Maybe there's something that we can do to prevent some of these complications and keep the kids safe. And a lot of parents who are expanding their families want to know the chance of this difference happening again. Do we need to plan families around it? Are there risks to my other children? And so now we're going to do the fun part where we go through some cases. And what I always want to emphasize is when we talk about differences, when we talk about kids, it's important to remember that all of these children have parents and families and friends, and they do have physical differences. And so it's really important. All the cases that I'm going to show are real people, real children, my patients. And so recognizing that someone has a difference is not disrespectful, but we have to be really careful when we're talking to families and the community about what a difference is. And so this is not my patient. This is a stock photo from Google. But can anybody tell me what they see in this child that makes them look for a little bit longer? And I didn't bring chocolate.
I would say her eyes.
Yeah, what about them? It's hard to say.
And her smile, it's reminiscent of, I want to use the right term. We used to call it Down syndrome.
Yeah, and we still do. And so you're exactly right. So in general, people's eyes go across like this. They're called people figures go like this. In Down syndrome, they're a little bit up slanted like this. You can have flattening of the side of the face. You can have a larger mouth. You can have broader thumbs. If you could see her ears, they might be a little bit squared off and a little bit simple. But exactly, you got this totally right. So this is a syndrome that most people have seen in the population. Nobody knows what it's called. It's called Down syndrome. And does anybody know how to diagnose this? So you're right. You're the geneticist. You went to clinic and you're like, I see these features. I think this is Down syndrome. But I want to make sure. How do we diagnose?
The blood test.
Yeah, exactly. So we look at the chromosomes. We take blood and we look at the chromosomes. And the tested choice for Down syndrome is a karyotype, which basically looks at all of the chromosomes, looks at their structure, sees how many there are, see if there are any physical differences. And that was actually the first genetic test that was developed in the 1950s. And behold, was the genetic test that actually revealed the cause of Down syndrome. Since the 1950s, we've gotten a little bit better. So there are a couple of more tests that we have in our arsenal. There's lots of words on the slide, but just to highlight, a chromosomal microarray just looks for little pieces of DNA that are missing or extra. So it has a higher resolution than a karyotype, but does not look for spelling changes. And a lot of spelling changes can cause disease. Gene panels look for spelling changes and pieces of DNA that are missing or extra, but it's limited. So you have to know what you're looking for, as opposed to a microarray or karyotype where you say, I think there's something missing or extra, but I'm not really sure which one. Then we got even better and we said, okay, let's do a whole exome sequencing. So instead of just looking at a specific set of genes, we're going to look at all of the expressed genes and see if any of them are missing or extra, or see if there are any spelling changes. And then we're in the process of getting a little bit better, where we moved on to whole genome sequencing, where instead of just looking at the expressed genes, we look at all of the genes and the regulatory elements and the junk DNA that we don't understand for spelling changes or missing or extra. But the problem is we really can't interpret this test. We don't know what most of the genetic material does. And so, as Wendy said, we should do our karyotype. And we do our karyotype and we look at the chromosomes. And what do we see? Remember, we're supposed to get one copy from mom and one copy from dad.
The fact that they're bent in anything.
No, it's a great question. So we actually swallow chromosomes underneath the microscope, and sometimes they get a little bit bendy depending on their position. Frustrating when you're cutting, but okay for kids.
Number 21.
Yeah, right, there's 3, right? So this is Down syndrome, where you have 3 copies of chromosome 21, and we can see it under the microscope. So this is a copy number change. Extra isn't always better.
I have a question. Is this, prenatal, is this tested while the mother is, while the child is still in utero?
So you absolutely can. So there are 2 ways to test right now prenatally. So you can do cell-free DNA, which is when you draw blood from mom and you can get some of the fetal cells in there and you can look to see if there are extra copies, and chromosome 21 is one of them. It's a screening test, and so technically the diagnostic test is an amniocentesis or a CVS, where you actually put a needle into the belly and take out some of the water or take out some of the chronic memphillus around the baby and actually do the same.
Is that still done to women only when they're in their 30s?
Great question. So now cell-free DNA is available to everybody who wants it. Amniocentesis is also available to anyone who wants it. There's a little bit of a higher, like, if you're going to do an amniocentesis, usually people say you should have a reason because of the miscarriage rate, but at this rate, you can do whatever you want. And not everyone who has a positive cell-free DNA elects to go on with the amniocentesis. And then the other thing, just because I don't want anyone to be confused, this karyotype does not belong to this girl, and the reason why I know that is because there's an X and a Y, so that's a boy's karyotype. But Google has limits, and this is one of them. So now you guys have done a great job. You recognize Down syndrome, you recognize this child. What are we going to tell her parents about what to expect in her life based on these physical features that we've recognized? There are much more senior geneticists in the room. I bet you they know what to tell a parent.
Life expectancy.
It is a little bit shorter. So in general, we tell these and most often we see these children as newborns because they're recognized the second they're born, sometimes even prenatally. And so we tell the parents that we should expect some learning differences. We're very careful to screen for heart differences. About 50% of the kids or more can have heart differences. We screen for low thyroid hormone because that can cause significant developmental differences if it's not caught. The kids have sleep apnea, so we screen for that also. Sometimes they need some extra help while breathing while they're asleep. We counsel them that they're going to get a lot of ear infections. They're probably going to need ear tubes. But the big one that we actually counsel for, which is really important and very popular in the media, is they can have some instability in their neck, which can be really dangerous to sports. So in the Special Olympics for kids with Down syndrome, we know to check to make sure that their neck is stable before we let them compete in sport. So these are things that we know because we've seen these patterns before. So we can tell parents, this is what we expect, and this is how we keep those kids safe. Does that make sense? So now we'll go into more common problems. Oh, sorry. And then for will this happen again? It's a higher risk with increased age of mom. And then there are special inherited forms of Down syndrome where parents carry a chromosomal translocation or chromosome step together. And that can have a much higher recurrence risk, which is why it's really important to do the karyotype to rule that out.
And then be tested prior to, is that one of the things that can be tested before the other?
Yes. So if certainly there's a family history of a Robertsonian translocation, they can test everyone in the family by karyotype to see if they have the translocation. And then as soon as the baby is born, if they're found to have a translocation, they immediately test the parents with the karyotype test. Not an array. Big mistake people make is they'll send an array, but if it's balanced, you won't see it. And so make sure it's the genetic. So this one's a more complicated one. And can you guys tell me what you see?
You got the cleft palate at the top, right?
Oh, so she does have a cleft palate, but I'm not a good enough photographer to be able to take that picture. That's her tongue. But yeah, it's definitely a significant difference in the tongue she has on hamartomas or little tumors growing out of her tongue. But she had a really good plastic surgeon, so that we were for reconstructing. I am not the plastic surgeon. But yeah, so she has a cleft palate, you're absolutely right. And she has a very abnormal tongue and a very prominent frenulum over here, which is a little piece of tissue that connects the tongue to the bottom of the mouth. Does anybody else become fine?
She has extra digits.
Yeah, she has a lot of extra digits. And in case you're not counting, when I actually did her x-ray, she had extra digits here. She has extra digits here. A lot of her digits are stuck together. They're split over here. And I think there's another, yeah, she has double digits here. So this is called polysyndactyly. So poly, they're extra, as thin as they're together.
So she have, did she got like 7?
Yeah, so this one this one ended up being 1, so it's 1, 2, 3, 4, 5, 6 for this one. 1, 2, 3, 4, 5, 6 for this one. 1, 2, 3, 1, 2, 3, 4, 5, 6, 7 for that one.
Is it in you, the top one, C only has 5, right?
Yeah, I can't actually, this one might be a double digit also.
You say would that be unusual for one to have even though they're not correct?
Yeah, so sometimes we see just 1 digit difference. It has to do with the signaling pathway that's affected in this condition. And so sometimes it's not all the digits. Sometimes it's interesting. Sometimes you see it on like 3 extremities. Sometimes you see it on 2. Sometimes you see it on 1. She happened to have all 4 affected. So guess what we would name a condition like this.
Is that clubfoot?
So she actually doesn't have clubfoot, but we called it oral, facial, digital, because we're just so creative. And so this child was referred to me because she had prenatal findings of abnormal kidneys. And so I was supposed to see her because of her abnormal kidney findings. And then she was born and there was more than just the kidneys. And so based on the physical features that I saw on exam, I was very worried that she had orofacial digital syndrome. And so looking at these features, you kind of think like, okay, what do we need to tell this family to watch out for? So like right now, you're like, okay, they have extra fingers and toes, like that doesn't really matter. Her tongue is a problem, but she had great plastic surgery. Like, is there anything else that we need to do? We handle the toes and once we handle them. And so the cosmetic features are what people see immediately. And the reason why this condition often goes undiagnosed is because nobody thinks about the internal complications. But they can have heart differences, congenital heart disease that you need to know to screen for. They can have learning differences, but the real thing that hurts these children is they have progressive kidney disease. And so there are 2 different ways that this can be inherited in an excellent dominant way. So it's only in girls for this one, and it's either inherited from a more mildly affected mother or new in the child, or autosomal recessive, which we'll go into, which was the mode of inheritance in this family. And so we talked before about how you get chromosomes from your mom and your dad. And sometimes your mom and your dad carry changes in the same gene, which is what happened in this family. So the green is the gene that doesn't work. The blue is the gene that does. And mom and dad are both carriers. So they carry a copy of the gene that doesn't work. And just by chance, they happen to pass it down to their child together. And so the child has 2 copies of the gene that doesn't work and then has orofacial digital. And so the Punnett square developed by Mendel can help us tell the family what to predict. So big A is what we use to denote the normal copy or the typical copy of the gene, and the little a is what denotes the copy that doesn't work. And so we do little multiplication, and we see that 75% of the time it works out okay. So carriers have no symptoms. People who have no copies of the gene that doesn't work have no symptoms. And then you have 2 copies of the gene that doesn't work, and those are the kids that get orofacial digital. And so that means that whenever this family has a child, just by chance, 25% of the children will be affected, or 1 in 4, and 50% of the children will be carriers. This family happens to have 4 kids, and this was their 4th. And so just by coincidence.
Is there a way of testing for this in an amnio or any
So
prenatal?
you could have tested for it in an amnio if you would have known. They were not going to terminate the pregnancy, so they didn't want to do any kind of risky procedure, but they could have done prenatal testing, found it, and then made decisions.
And I have another question about the amnio. Let's say I decided I want an amnio, but I have no history of anything, but I want one just to see, will my insurance pay for it?
Mine did.
Okay. Did you have to argue with the insurance company? No.
You didn't have to prove there was any kind of risk, any kind of, you didn't have.
No, it just said wanted to be a
Tay Sachs,
geneticist,
you
and that
didn't
was
Tay
the only
Sachs
justification.
or Lynch syndrome relevant or anything like that.
I think insurance companies are probably getting a little bit better about it. I don't do prenatal, but I see a lot of the families afterwards, and many of them have had amnios, and I've never heard them say that there's been any kind of an issue with coverage for prenatal testing. I think a lot of people make medical decisions based on prenatal testing, and so insurance companies realize also possibly the anticipated cost of a child with a congenital difference, who parents might make the decision to terminate a pregnancy, which will ultimately be money saving for the insurance, which isn't a great reason, but maybe they've done the calculus and figured it out.
If you could go back to Down syndrome for a moment,
Yeah.
you don't have to with slides and all that, but I noticed you had learning differences in this list, but it wasn't in the Down syndrome, was it?
I think I did developmental differences. for
Oh,
them.
did you? Okay.
Yeah, yeah.
Oh,
So
okay, I'm
learning
sorry.
differences- Yeah, no, it's totally fine.
Can they do surgery to correct the digits on one
They
hand?
can, and it's interesting, oops, sorry, I think I went by it, so for her, they usually don't do the toes, because you don't see the toes and it doesn't affect walking. She actually ultimately did have her extra digits removed and her digits separated, because it helps with dexterity. They usually do it when they're doing other procedures at the same time. So, and she also has like pretty significant kidney malformations that have required surgery, and so they just go every time that she's under and take it off. Their Chuck has a special hand plastic surgeon, and so all he does is the hands, so that's a benching special.
You say progressive kidney, what does that mean?
Yeah, so for oral facial genital, starting at about the age of 10, the kids are at risk of kidney dysfunction. The reason why is the gene that's missing in these kids is really important in making tubes, and the kidney is made up of a series of tubes. So over time, the kidney function gets worse and worse because they can't do maintenance of the tubes important for the kidney. And so it can range anywhere from severe kidney differences that you're born with to like end-stage kidney disease in your 6th or 7th decade. And so that's what we watch out for in these kids, because if you don't have a diagnosis, you present with renal failure, which is one of my other patients with this condition. I told you guys a lot about the benefits of having a genetic diagnosis, which helps us screen for complications, which helps us do things to keep these kids safe and help families know their recurrence risk. So for this family, they knew that if they had more children, they would have a 1 in 4 chance of having another one affected with orofacial digital. And they made the decision to screen their other children to know if they were carriers who can also have risk. But
Were they?
so one of the children was, and then one of the children was not. But it's a little bit of an ethical discussion, whether it's okay to carrier screen people who are not of reproductive age because they can't consent. So their kids this was a surprise baby, and so their kids were actually here, and so they were able to consent for it. But it's important information for a lot of people who want to start families to know what the risk is. But not every child that comes to our clinic, we are actually able to get a genetic diagnosis for. So depending on the indication for testing, you can often not be able to make a molecular diagnosis 40% of the time. And that's a really big deal for families that want to know how to screen for complications, and want to keep their children safe, and want to know the risk of this happening again. So one of my research goals is gene discovery for liver and kidney disease. So kids that we really think have a genetic cause for their liver or kidney disease, but we do molecular testing and there's nothing. And so this is one of the patients that I got to see in clinic. He was a 23-month-old male when I saw him. He was born full term, the pregnancy was uncomplicated. For 4 months, he was hospitalized because he wasn't gaining weight. And while he was in the hospital, they noted that his liver enzymes were elevated, his blood pressure was really high, so they took a look at his kidneys, and the kidneys looked abnormal, and he also had chronic kidney disease. And so they sent a microarray to look for pieces of DNA that were missing or extra. And they sent the cystic kidney disease panel to look for genes that commonly cause kidney stone. And there were no recordable variants. Then at 6 months, he developed this really abnormal skin rash that they thought might be erythema multifocal. And that's his skin rash. Then at 13 months of age, he presented to the emergency room with left arm and left leg weakness, and he was diagnosed with a stroke. At 18 months, they decided to do exome sequencing to look at all of the genes to see if there was anything missing or extra. And it came back negative. So there was no genetic change that could explain what was going on. And at 20 months, he presented again with another stroke. And they did an MRI that showed moyamoya disease. Now, moyamoya disease is a very interesting condition of the blood vessels of the carotid. So how it starts is the carotid artery starts to narrow. And the brain does not like not getting blood. And so it makes these collateral vessels to try to increase blood flow to the brain. And they look like puffs of smoke. And moyamoya means puffs of smoke in Japanese. And that's it for this condition, is the most common. But these blood vessels are very fragile. And so just a little bit and they can break, and that's a stroke. And so we don't know very much about moyamoya. It's associated with some syndrome, but it's most commonly caused by a change in this gene RNF213, which causes isolated moyamoya disease. So just moyamoya disease, nothing else. And so we decided that maybe we should look at his genetic material for ourselves and see if we could find anything that could explain what was going on. And lo and behold, we found a change in RNF213 that was new in him, so neither of his parents had it, and it was disease causing based on classification. And so the question is, well, okay, we can kind of explain his moyamoya, but he's so much more than moyamoya. He has liver disease, he has kidney disease, it's a really strange skin rash. And so does he have 2 diagnoses or does he have 1 diagnosis? And so first you have to take a step back and think, is this biologically plausible? What do we know about RNF213? And exactly as its alternative name implies, Mr. N, we have no freaking idea. So we know that it probably plays a role in blood vessel formation. We think it plays a role in the immune system. We think it plays a role in the cells that line the inside of the blood vessel, their growth, and we think it plays a role in inflammation. You know. And so because we have no idea what we're talking about, we have different ways to be able to get a little bit smarter. So BD is my patient. And then what you do is you go onto genetics Facebook, which is Gene Matcher, and you say like, hey, I have a patient with a variant in RNF213, and this is what they look like. Do you have a patient that sounds like my patient? And a neurologist in New Zealand wrote to me and was like, dude, I have a patient that has a change in RNF213 that also has liver enzymes that are high, also has kidney disease, also has this really weird skin rash, and also has moyamoya. And we're like, dude, 2 people across the country, this is probably real. And then we can also search biolinks. So in the Center for Applied Genomics at CHOP, we have a whole collection of patients, over 100,000, that we know what their diseases are, and we have access to their genetic material. And so we found a patient in the biobank who, based on our genetic testing, has a change in RNF213, who also had liver disease, kidney disease, really unusual rashes that were noted in his chart. And in fact, he had an intrauterine stroke and was diagnosed after he was born with moyamoya. And so once you have 3 patients from 3 different universes that look exactly the same, you can be pretty confident that you have a real pattern. And so we decided that RNF213 is probably also a causal gene for syndromic moyamoya. And then we published it. And so now we wanted other people to know so the labs could call it when they started to get testing back. And so who cares? Like, why did we bother to do this? Why did we bother to publish this? Aside from being able to tell the family why this happened and the recurrence risk, which is very low because it was a new change in the child, but very high for this patient when he goes on, why is this important? And so the reason why this is important is because if we saw it once, we're going to see it again. And so about a year after I saw BG, I got to meet JC. So he was a 15-month-old male. He was born full term. He was healthy. He did great until 7 months of age when he got COVID. And he presented to the hospital having seizures. His electrolytes were insane. He had acute kidney injury. He needed dialysis. He had really high blood pressure. His red blood cells were being destroyed. And they diagnosed him with a condition called atypical hemolytic uremic syndrome. And it resolved. He went home. But then he represented at 11 months with atypical HUF again. And he had high liver enzymes, he had worsening kidney function, and he had this really unusual skin rash. And the dermatologist called it sweet syndrome, which is a febrile neutropenic rash, but it didn't have a fever. And so it wasn't a great diagnosis. And so I got to see him in clinic, and he still had the rash. And I was like, I'm not a dermatologist, but I've seen this rash twice before, in my CHOP patient and in the New Zealand patient. And so I was like, maybe like he doesn't have moyamoya, but we talk about patterns in genetics. So we have these 3 patients, and now let's compare him to JC. So he has high blood pressure, he has high liver enzymes, he has immune conditions that affect the kidney, and he has these really unusual rashes. He doesn't have moyamoya, but he possibly had a change in RNF213. And so we sent genetic testing. And unfortunately, Dad was not available to be able to participate in testing, but we know he has a variant in RNF213. We know it's not inherited from his mother. We don't have access to his father. And so we said, okay, let's screen him for the complications of RNF213 to protect him in case this is real, so we can do surgery to prevent him from having a stroke. So at 11 months, he had had an MRA to look at the blood vessels in the brain, which is something that they do as part of the HUS workup. And then we said, okay, MRI every 6 to 12 months. So when he was 18 months old, he had another MRA that showed new narrowing of the internal carotid and new narrowing of the anterior cerebral arteries. So it's showing an evolving moyamoya as we watch. And so this is really, really, really important because there are surgeries that you can do before they develop full-fledged moyamoya to be able to revascularize the brain so they don't make these abnormal vessels. And now that we know to do it, we can watch him every 6 to 12 months, and the hope is that he will not stroke. because we were able to find this gene and get that diagnosis. So this is what gene discovery is important. If we have time, I have a section on gene characterization. We don't have to.
If I may just ask quickly, when you say, you know, at 13 months, they tested for this, what, is it all of these different doctors, a neurologist, you know, nephrology, are they all coming to you and you guys all work as a team?
Yeah.
So you see the patient from a doctor's standpoint as a geneticist though?
Yeah, so it's a very interesting way the world has evolved. So right now, historically, genetic testing had existed only within genetics because the only genetic testing that was done was for syndromes. But now, if you have like a cardiomyopathy, your cardiologist might send a gene panel for cardiomyopathy. If you have cystic kidney disease, your kidney doctor might send a gene panel to look for causes of cystic kidney disease. And they only go to a geneticist when they either need help interpreting those test results, or if those test results don't have an answer and they want to move on to a more unbiased test like an exome or something more advanced. So for this child, his testing, he didn't come to CHOP to begin with, so his testing was sent by an outside nephrologist. And then by the time his testing was, the outside nephrologist referred to CHOP metabolism actually, because one time he had elevated lactate, and metabolism was like, we should probably enroll him in research. And that's how I got to see him clinically and in our research setting.
Had he already had the stroke?
Yes. So by the time I saw him, he'd already had the stroke. We're not 100% sure why the lab didn't call the RNF213 variant that was obviously there. When I spoke to them, they said the reason they didn't call it was because he had a stroke, but they didn't write in the note moya, and the liver disease and kidney disease was not known to be associated with RNF213, and so they didn't feel that it was a good picture, and they're not wrong. Because it was a totally new association in a clinical lab, you're not allowed to do that. It's only in a research lab where you can say, I think this might be it, and then do this kind of investigation.
That's fascinating. So you have so many doctors, but you are doing the extended homework on behalf of all of these doctors and giving them back the information, and you all are figuring out how this all comes together.
Exactly. So I am the most useless doctor on the team. So like, I can't treat their kidney disease. I can't treat their liver disease. I can't treat anything, but I can say like, this happened because X, Y, Z. And then they'll say, well, what happens when it's time for a liver transplant? And you say, that's a really great question for your hepatologist. And so it becomes like a little bit of a, like, I'm an outside player.
You give them the puzzle pieces though.
That's what we try to do. We help with saying like, you're going to need to see these doctors. This is the risk of it happening again. This is the risk your other children are carriers. This is how we keep your kids safe. But all of the management of like the liver disease, the kidney disease is done by their hepatologist and nephrologist.
What's the protein that are concerned?
Misterin is the protein it makes. We were creative.
You know, what is the structural protein?
Yeah, so it's an E3 ubiquitin thing. Oh, here it is. Yeah. Yeah, it has a ring domain, but like we literally have no idea. It's an E3 ligase. It has this motor domain over here. It has an N-terminal arm. Like, this is the most up-to-date thing. You have no idea what it does. We just published a bigger cohort and we still don't know what it does. Like tons of patients, including Canadians. And we did the functional studies to try and figure out what it does. We tried to see if like the gene change correlates with the disease. We don't.
So basically, realizing that this kid was similar to the other two children you've seen, you basically saved this kid from having a stroke and having a very handicapped one.
I hope so. But that was the point. That was the point of doing it. So it's like a nice plug for why it actually matters to sit in a lab in front of the computer and look at variants. But the key is like the role of a geneticist is to take a step back and look at patterns, say, have I seen this before? Where have I seen it before? How can I tell if I'm right? And then how do I use this information to protect the children? We don't have to do gene characterization. We should do it. Okay. So part of the fun is gene discovery, absolutely for sure, because it translates immediately to being able to go back to the family. Gene characterization takes a lot longer, but the ultimate goal is once we discover these genes, how do we use that knowledge to be able to design a treatment? So we're not just keeping the kids safe, but we're actually fixing them. And so this is another condition that we were able to do both gene discovery and gene characterization for. This is a really interesting condition described in the 1970s by Dr. Hardekar, and this is Hardekar syndrome. And what Dr. Hardekar realized is that there were a series of girls that all presented with clefting. They all had differences in the back of the eye. They all had coarctation of the aorta, which is the big tube that comes off the heart. They all had abnormalities in the tubular system of the liver. They all had their intestines all twisted up. They all had kidney differences. But at the time, we didn't know the gene. And so we did our same gene discovery project and identified variants in a gene called MED12 that caused this disease. And so MED12 is super interesting. It maps to the X chromosome, which explains the girl only, and it encodes a component of mediator complex. So it's right over here. And mediator complex controls gene expression. So it mediates the connection between transcription factors and enhancers to help control which genes are expressed and which genes are turned off. And so the question is, well, how does a change in gene expression from MED12 cause a condition like Hardikar syndrome? And so again, the point of a geneticist is to notice patterns. And so there's a whole class of disorders called ciliopathy, which have retinal disease, liver disease, kidney disease, brain disease, lung disease, heart disease, twisted intestines, and bone differences, which looks an awful lot like Hardikar syndrome. And so the question is, well, is the way that Hardikar syndrome causes disease is by disrupting the cilium? And so nobody likes the cilium, but it's actually a really important part of the cell. So this is the cell down here, and the cilium is like the submarine camera that like pokes out from the cell and looks around and says, okay, this is what's going on around here, and then reports back to the inside of the cell. So it's really important in helping cells grow in a coordinated way and respond to their environment. And it's really, really, really important for making tubes like blood vessels and the inside of your liver and kidneys and intestine. And so the first thing we do when we have a hypothesis and we're thinking about a gene is we ask what happens when we screw it up. And so this is immunofluorescence, where we can actually look at cells. The nucleus of the cells are in blue, and the cilium I stained in red and also green. And so what we did is we took cells and we did a control group where we didn't screw them up. And then we knocked down MED12 and we asked the question, is there something different about the cilium? And the answer is yes, there are fewer cilium when you knock down MED12. And so this suggests that MED12 does affect the cilium, but having less doesn't necessarily mean that you're interfering with function. So the next thing we wanted to do is we wanted to ask whether the function of the cilium is affected by not having MED12. And the classic way to look at that is to see how well cells respond to a growth factor called hedgehog. And so GLE1 is a downstream gene of hedgehog. And so when hedgehog is signaling, GLE1 goes up. And so you can see in the normal situation, when you treat cells with a hedgehog agonist called SAG, you have induction of GLE1, so GLE1 goes up. In cells where you don't have MED12, you lose that. And so in addition to not having as many cilia, they also don't work. And so there's a lot more science that went into that, but it's just kind of a cool example of how we take clinical findings into the lab to be able to understand better what is actually causing the disease, which we unfortunately still haven't been able to do from this strand. But to summarize, geneticists is the best job in the world. And so for anyone that wants another career, it's a really fun thing to do. It's really nice to work with families who are invested. The families who come to you come because they're invested in their kids. They want to know what's going on. They want an answer, and they will do anything to help you. So enrolling in research is time consuming for families, but they're motivated and they want to do it, and it's really rewarding. It really helps with anticipatory guidance and family planning. So sometimes you say, like, there's nothing I can do for your child, but them having the knowledge and power to know this won't happen again or this will happen again is really important. It provides great opportunities for gene discovery. So you can learn new biology, you can help families who have been on a diagnostic odyssey end their odyssey, and it's also a really great opportunity to discover new biology. So new pathways, new ways genes are regulated, how genes work. Thank you guys.
Absolutely. More complicated aspects of what you're doing. I mean, that's what kind of before we come and ask. And I mean, it's both exciting to prophesy, for want of a better term, as to what diseases the child might get in the future. But it's also scary, isn't it?
Yeah, so there's a lot of crime in genetics, both on the part of the doctor and on the part of the family. So like yesterday, we had a family that they have a child that has a mitochondrial disease. their middle child just presented with kidney disease, we sent genetic testing, they have a ciliopathy, and they have a younger daughter who they viewed as their healthy one, and you have to test her because it can be a later presenting thing and she's affected also. And so they have a child with mitochondrial disease and who's in kidney failure from this mitochondrial disease, and then 2 kids with a known disease that's going to cause kidney failure. 2 parents, 4 kidneys, 3 kids. We're going to need them. And so that's a devastating discussion to have with families. So you tell them, like, we're gonna watch your kids, we're gonna watch their kidneys fail, and we're gonna keep them safe by sending them to nephrology, so it's not a surprise. But like, it's not a great discussion. The worst ones are neurodevelopmental conditions with progression, where you diagnose the older sibling and they sit there waiting to find out whether the younger sibling has it. And sometimes the younger sibling does have it, and you tell them there's nothing you can do, and it's both going to go. And so it's not always an easy job to have, but an important job.
Are there new tests that people who intend to have children should take? Years ago, when people would say, oh, for Jewish people, get T-sex testing. And there's something called J-screen that I've heard of. What are there more tests that people should
Yeah, so
get?
you can have expanded carrier screening. So right now, carrier screening is done by looking for changes in a series of genes that are associated with common conditions, so that the incidence of those diseases in the population is high enough that it's effective to screen the population. And so advantages of this is that you're going to capture all the high yield common conditions. Disadvantages include a couple of things. The SEP164, which is what my orofacial digital patient has, is so rare. Even if the parents would have had carrier screening done, that gene would not have been included. And so they never would have known. The other thing is that we have a lot of genetic changes that we don't know what they mean. So we call them variants of uncertain significance, because like everybody has about 500,000 different changes that make us like different, but they're not diseases. And so for diagnostic testing, once a baby is born, they will report variants of uncertain significance. For carrier screening, they will not. Because what do I do if I find that I'm a carrier of a variant of uncertain significance in a gene that causes disease? I can't plan a pregnancy around it, the kid might be normal. And so we have a lot of families that have done carrier screening, and the kid is born with a condition that they tested negative for because they have a variant of uncertain significance. And so we didn't know. And so no matter what you do, you can still have problems. Another important thing to consider is sometimes the changes in you and the child. So even if you've had carrier screening, it's not a condition they carry, it's new. And so you'll miss them. So
There's a difference between screening for carriers and screening for dominant gene.
yeah, so for some dominant conditions, you can be a carrier of, which you're not really a carrier, you can have it. But there can be different degrees. So for example, I saw a child with kidney cyst and heterotaxy, which is where your heart is assembled in a different way, it's like twisted on an axis. And so he ended up having Loeys-Dietz, which is a dominant condition. And his father was the one who had Loeys-Dietz, who had no idea. He had no heart disease, no nothing. And his mother, so like his paternal grandmother, also had Loeys-Dietz. And so it's not on carrier screening because you assume that if they have Loeys-Dietz, but they have it also. And there are a couple of conditions they screen for that are technically like dominant, and you can sometimes diagnose parents on their carrier screening, which happens a lot for some recessive metabolic conditions and some types of conditions.
Following Wendy's question, a little bit, I thought it was a really interesting question. Is there a battery of tests that you as a geneticist would recommend to people who are thinking about having children, and what conditions would they not find?
Yeah, so we always recommend Fragile X syndrome. So the most narrow ones is Fragile X, SMA, which is spinal muscle atrophy, sickle cell disease, cystic fibrosis are some of the more common ones. We recommend carrier screening panels. So there are a couple of different companies that have panels that screen from around like 300 different conditions. And so we recommend that they screen for that. And if there's a family history of a genetic condition that's not covered on those panels, we recommend screening the person who is in the family that has the condition to get tested for the familial variant. And that's kind of the best coverage we have now. Things that are missed are things that aren't on the panel. So the panels only have 300 genes on them. There are 20,000 genes in the genome, so you're missing quite a bit. New changes we can't screen for. Copy number variation we can't screen for that way. Robertsonian translocation, which is one of the genetic causes of Down syndrome, we can't screen for that. So you do, and epigenetic things, which are usually new in the children anyway, you can't screen for.
Out of curiosity, this is just an uneducated, non-science person here. When we mentioned that, women who are pregnant at an older age have a more likely chance of Down syndrome.
Yeah.
So what changes if your genes are your genes? What makes an elder?
Great question. So advanced maternal age and advanced paternal age do different things. So you're born with all of the eggs you're ever going to have when you're born. And they sit waiting. And then when you ovulate, they finish meiosis, so they finish division. So it turns out that when you have the egg sitting in your ovary just waiting for its day to shine, the chromosomes are together. And then they separate as you go through ovulation. As you learn that the eggs have been sitting around for longer and they've been together for so long that they don't always want to separate. And so when that happens, if you have an egg that has 2 chromosome 21s and it gets fertilized by a sperm that has 1 chromosome 21, now you have Down syndrome. One of the other thought processes is that in addition to actually having this non-destruction event of the chromosomes that stay together, is that you're more likely to self-abort a pregnancy when you're younger than when you're older. There are lots of evolutionary reasons for that. So trisomy 21 or Down syndrome, you often will have a miscarriage when you're younger, but won't necessarily have it when you're older. For men with advanced paternal age, their sperm are always renewing, and so they're not old, but they have a higher incidence of spelling changes in genes. So there are certain conditions that are associated with advanced paternal age, but women talk about. So achondroplasia is associated with advanced maternal age. With FGFR3, it's a single change, and for whatever reason, when men get old, they decide not to fix it, and it just becomes a change. That's the most common class one.
Then one more question, because I know the older we get, my father just passed away from cancer, but he was 86. So he makes it to 86 without knowing a single thing. Are these, when you say these screenings, are these the tests that people like me can take to see if maybe this is something that isn't, and are things covered? Like she was asking, are those covered by insurance? Because now all of a sudden it's in my history.
So BRCA testing is covered for Ashkenazi Jewish women unequivocally. I don't do cancer genetic screening, so that's the only one that I know is covered, but they have large cancer panels. The problem with cancer genetic testing is that so often the person who comes is the relative of the person who had cancer. And it's tough to say, because if I send a test on you and you don't have a genetic change associated with cancer, I don't know if that's because you didn't inherit the genetic predisposition in the family, because there wasn't a genetic predisposition in the family, or because you have a yet undiscovered gene that causes cancer in your family, and no matter what I do, I'll never find it. And so there are lots of families that go back to the hospital where their relative with cancer died to try to get DNA to be able to do that testing. Because it's important, they want to know for their children. They didn't think about it while the person was alive and they were in the midst of their cancer treatment, and then want to know afterwards. There's more of a drive now to do genetic testing immediately with a cancer diagnosis, because now it's affecting treatment. So like depending on what the cancer markers are and the genetic lesion is, you treat differently. But yeah, in terms of cancer screening in general, Adele, I've never seen someone with no family history that just wanted to do it.
People are doing it all the time now.
Amazing.
There are 2 Jewish organizations where you can get cancer genetic screening. One is called yodea.org, and you can go on there and order a kit. Depending on who's giving an extra grant, it may be $99 or $159. And then screen maybe 20, 30 genes. Or you can go to JScreen, and they do cancer screening as well. And it's the routine kind of BRCA, Lynch, and those kinds of genes. But they're sequencing, so they're looking not just at specific mutations, they're looking at the whole gene. So those are good tests, and some of them will bill insurance, and that's all they'll charge you. Most of them do some kind of genetic counseling beforehand. But your best bet really is to go to your local cancer center, where there's a genetic counselor who will do family trees, see what you're at risk for, and then send off your sample and use insurance.
Do they report buses on the panels that are direct to consumer? Because that's a office.
You know, I had mine done a long time ago and they did not. I'm not sure what they're doing now. But if you go to a genetic counselor at a cancer center, if they do, you have someone that can talk to you about it.
The reason why that's important is because of variant of uncertain significance, you don't know if it's disease causing, so like, if you have no personal cancer risk and no family history of cancer, and you have a variant of uncertain significance in BRCA1, and you're at a point where you would be thinking about an oophorectomy and you would be thinking about a mastectomy, it's hard for a variant of uncertain significance to know what to do.
The other thing that I sort of have a recommendation for, which is if you've got elderly parents, even if they're healthy, you can collect blood and have DNA banked for them. So that if at a later stage, you do want to do family genetic testing, you have their DNA. So I did that with my mom. She died, I don't know, maybe 7 or 8 years ago. But I did that before that. We have her sister as well. And if our family ever needs that, we have the DNA, and I think it's time for us to do it for ourselves now. So
Wow,
our kids have that.
so what does that mean? If both of my parents are gone, do their siblings, is DNA from their siblings helpful?
Yeah, anybody at any level of the generations, there's a lab called Prevention Genetics that has a DNA bank. When I did it, it was $100. I don't know what it costs now.
Fascinating.
Did you say prevention?
Prevention Genetics.
What was that other, before you said J screen, there was some other,
Rodea,
Yodea?
yeah, YODEA, Dr. It's out of my name.
So that is something people should consider doing, like we should consider doing for our children at this point.
Yeah, that's what I'm thinking.
Brilliant.
On the way out, I guess, where everybody gets their.
I may not be doing it with cheese
Cheese
swap
swaps,
now.
yeah.
Anyone else? Thank you so much. That
Thank
was-
you, guys.
Thank you. And what I appreciate, like I said, I think I may be the only non-scientist in here, but. But you made it so understandable.
Thank you very
Oh
much.
my God.
This is from Mr. King. I invited her.
Thank
I tried to invite all of her former teachers, but only one responded, so that was good.
you. Very much, that's really nice.